Okay, let's be real. If you're studying for the NCLEX, you've probably got lists of lab values coming out of your ears, right? It feels impossible to cram them all into your brain. But what if I told you there's a way better, way smarter way to do this? Yeah, that feeling of just drowning in numbers, we've all been there. But listen, today we're going to throw that whole strategy of just memorizing stuff right out the window. We're going to replace it with a powerful framework that helps you think like a real nurse, a safe, effective nurse, which, let's be honest, is exactly what the NCLEX is looking for. All right, let's cut right to the chase. This slide right here, this is the golden rule. If you only remember one thing from our entire chat today, make it this. The NCLEX doesn't care if you can spit back a number. What it really tests is if you can see that lab value inside the whole picture of a patient, their symptoms, their meds, how the lab is trending, and then make a smart, safe clinical call. This single idea is the key to everything. So here's the game plan. We'll kick things off with that golden rule, then dive into the really critical stuff: electrolytes, glucose, and coags. After that, we'll hit CBC, kidney, and cardiac labs. And then the best part, we'll tie it all together with the NGN model and even run through a quick practice scenario. Sound good? Let's go. Okay, so let's officially start with section 1, our golden rule. And it's simple. The NCLEX is a test of safety. It's about what you do. It's not a trivia night at the local pub, you know? When you see a lab value, the real question the NCLEX is asking is, okay, so what are you going to do about this? Think of these 3 questions as your go-to mental filter. For every single lab question you see, don't panic about the number. Just run it through this filter. 1, is this lab value dangerous, like life-threatening? 2, is it new, or is it getting worse? And 3, this is the big one, does this require me, the nurse, to drop everything and act on it right now? That right there, that's clinical judgment in a nutshell. All right, let's jump into our first group of labs, and these are the big ones, electrolytes. Why are they so high priority? Well, because even a tiny little shift in these values can cause huge problems for the heart and the brain. And you better believe the NCLEX loves to ask about things that can cause immediate harm. And we're starting with the king of all electrolytes on the NCLEX, potassium. Seriously, this one is huge. Just think of potassium, or K+, as the electricity for the heart. If it gets too low, that's hypokalemia, you're looking at scary heart rhythms, these dysrhythmias. But if it gets too high, hyperkalemia, you gotta watch for those classic peak T waves on the EKG. That's a huge red flag for potential cardiac arrest. Either way, it's an emergency. Now this is a classic, we're trying to trick you, NCLEX safety question. So burn this into your brain. You never, ever give potassium IV push. It is lethal. And just as important, you always, always check the patient's urine output before you even think about giving it. Why? Because the kidneys are what get rid of potassium. If the kidneys aren't working, that potassium is just going to build up and up to toxic levels. It's a huge safety point. Okay, for the other major electrolytes, here's a super quick and dirty way to remember them. Just link each one to a body system. Sodium, it's all about the brain. Think confusion, think seizures. Calcium, think muscles. Low calcium causes tetany, that rigid muscle contraction, and you'll see those telltale signs: Chavostex, the face twitch, and Trousseau's, the wrist spasm. And finally, magnesium. Mag is all about reflexes. Too much magnesium and everything gets floppy. You're worried about respiratory depression and reflexes that are just gone. All right, moving on to our next big category. This group covers 3 absolutely vital functions: fueling the brain, keeping the body's pH in balance, and managing bleeding risk. And yeah, each one of these is a major NCLEX favorite. So, blood sugar. This is all about recognizing the signs, right? Hypoglycemia, low sugar, is when the brain is literally starving, so the patient gets shaky, sweaty, confused. Hyperglycemia, on the other hand, is your classic free peas and that super distinctive fruity breath you see in DKA. Now, what's the NCLEX rule? You always treat low sugar first. Why? Because brain damage from hypoglycemia is fast. Just remember that old saying, cold and clammy needs some candy. Okay, ABGs. I know, they look super intimidating, but you can actually read them in seconds. It's a simple process. First, just look at the pH. Is it low, meaning acidosis, or high, meaning alkalosis? That's your first clue. Next, look at the PaCO2. That's the lungs. If it's going in the opposite direction of the pH, bam, it's a respiratory problem. If not, then look at the HCO3. That's the kidneys, or metabolic. If it's going in the same direction as the pH, you've got a metabolic issue. Simple as that. Next up, coagulation labs. These are almost always tied to high alert meds, so they're super important. If your patient is on warfarin, you're glued to that INR. If it creeps up over 4, their blood is way too thin. You're holding that dose and getting on the phone with the provider, stat. For a patient on a heparin drip, you're watching the APTT. You actually want it to be elevated, usually between 60 to 80 seconds, to know the drug is working. And then there are platelets. If the platelet count is low, your patient can't clot, so you immediately put them on bleeding precautions. You know the drill: soft toothbrush, electric razor, no sticking them with needles if you can help it. Okay, on to our next set of labs. Think of these as the body's dashboard indicators. They give us a quick snapshot of 3 huge things: how well we're carrying oxygen, how we're clearing out waste, and whether the heart muscle itself is damaged. Let's run through these real quick. Hemoglobin, or HGB. If it's low, it means less oxygen is getting around, so your first move is to assess for shortness of breath and fatigue. Next, white blood cells, WBCs. A high count means infection, sure, but on the NCLEX, you gotta worry about a low count. A low WBC count plus a fever, that is a neutropenic emergency. Then there's creatinine. This is hands down the best indicator of kidney function. If that number is high, the kidneys are failing. Simple as that. And finally, troponin. Any, and I mean any, elevation in troponin means heart muscle is dying. You treat that patient like they are having a heart attack, no questions asked, until it's proven they're not. So, we've gone through a ton of numbers, but here's where the rubber meets the road. How do you actually apply all this? And that's the entire point of the next generation NCLEX. It's not about what you know, it's about what you do with what you know. It is all about clinical judgment. So here it is. This is your NGN decision filter. When you're in the exam and you get a question with a lab value, just run it through these 5 steps. Ask yourself, is this number critical? Is it trending in the wrong direction? Does it mess with the ABCs or their neurostatus? Does it force me to change my plan right this second? And finally, could this lab make a medication I'm about to give unsafe, like giving digoxin to someone with low potassium? If you get a yes to any of those, that's where your focus needs to be. That's your priority. And this is literally how the NGN is going to test you on this stuff. Forget just simple multiple choice. You're going to see questions where you have to physically click on and highlight the abnormal labs in a patient's chart. They'll ask you, based on these labs, is it safe to give this med? Or they'll make you drag and drop nursing actions into the correct priority order. See, it's all about application. And to help you make those connections super fast when you're under pressure, use these memory anchors. They are simple, but they are so powerful. Potassium is heart, sodium is brain, glucose is also brain, INR is bleeding, creatinine is kidneys, and troponin is heart damage. Just lock those in, they'll point you to the right body system every single time. Okay, you've got the golden rule, you've got the key values, you've got the NGN filter. Now it's time to put it all together. Let's run through a quick scenario and see what you do. All right, picture this. You're in the ED. A patient comes in and their chief complaint is new onset confusion. Right away, your nurse brain should be spinning, right? What are the possibilities? Okay, now we get another piece of the story. You look at their chart. History of seizures. Okay, so new confusion in a patient with a seizure history, that definitely raises the stakes. What labs are jumping to the front of your mind right now? And then the labs pop up on your screen. And there it is, sodium, 120. Whoa. Okay, remember our anchor? Sodium equals brain. Normal is around 135 to 145, so 120 is critically dangerously low. This explains the confusion, and it puts this patient at a massive risk for having a seizure, like right now. So that brings us to the final question. You've got all the data, the confusion, the seizure history, that scary low sodium. What is the nurse's #1 priority action? What do you do first? The answer is all about safety. Your immediate priority is to put this patient on seizure precautions. That's your first move. That means patting the side rails, making sure you've got suction ready to go at the bedside, clearing anything that could hurt themselves on. You have to protect the patient from harm first. Then you can call the provider and get ready for whatever they order next. See how that works? You identified the immediate risk, seizures, and you acted to mitigate it first. That is what being a safe nurse is all about.